drug is a safe product for me to take. So it's a very real problem. I'm one of those 20, and I just wish my son, I guess, had known the real dangers of what it will do. I've heard a lot of statistics today. You know, my opinions on it is, you know, the FDA just now has approved OxyContin for use down to, I guess, to the age of 11 years of age. And to me, that's a crime. That's setting our youth up for failure. And we've got to do something about it as Tennesseans. I would say as Tennesseans, you know, if the federal government, the Department of Veterans Affairs can basically say we're going to limit the use of various medications to ensure appropriate use, why can't the state of Tennessee do that? Why can't the state of Tennessee basically say, you know what, we're going to totally limit the usage of OxyContin? My mother-in-law just had shoulder surgery. She walked out of the pharmacy with 100 OxyContin. She is 72 years of age. There's no reason for her to have 100 OxyContin. I would also say this, you know, I work for a pharmaceutical company. Again, they do a lot of good things, but why can't the manufacturer, Purdue Pharma, for example, why can't they be partnering with Tennessee with this? Why can't they be forking over $1 million to help educate?
Amen.
So in closing, you know, we've got to educate our youth. It is a problem out there, and I just wish that, you know, my son had known the real dangers of it. So thank you.
Well, thank you, Austin. Thank you for coming and telling that story. And tough to do, and we thank you for that. Dr. Frieden, why don't you react to what you've heard, and then why don't we go to the experts in the, I don't want to say audience, but let's say the experts out there, and see what comment or question you might have. I know Bill Dunn may have one, so Tom, why don't you react?
Well, first, Mr. Maxwell, thank you so much for sharing your story. Public health is at its best when we see and we help other people see the lives and the faces behind the numbers. And parents and families, yourself and others who come forward are really helping to save lives. And we really appreciate your willingness to do that, so thank you. I think, Dr. Dabbs, the challenge of emergency department physicians is real. One of the things that we've done is to work with the American College of Emergency Physicians to come up with guidelines for prescribing in the emergency department. I know of some emergency departments that have said, you know something, we don't prescribe long-acting opiates here. There have been some legal challenges about that. Is that legal? Is it discriminatory? But at most, you have to understand, we're not going to give you a week's supply. We're going to give you 48 hours supply, and then you go back to your regular course of care. And if you've got a problem with addiction, we'll refer you there. Because addiction is an illness, and we need to treat it as an illness. The issue that Dr. Reagan mentioned of the prescription drug monitoring program, there are some pilots where there's been an integration of the prescription drug monitoring data system with the electronic health record. So that it's a single sign-on. You don't have to sign on to a different system, close this, open that. Those pilots have shown big decreases in the amount of inappropriate prescribing. So that's something that might be possible, at least for some systems. What we've learned about electronics is it's always harder to do than you hope it would be, but we hope that would be possible. And Dr. Reagan, I was really interested in your comment about the 10% reduction in opiate prescription. We've seen big reductions in Kentucky, a few other places. If you look around the U.S., there's a threefold difference between states in the amount of opiates prescribed, and frankly, even with the lowest ones, there are too many opiates being prescribed. This is a tough message to bring because exactly the issues that Dr. Dabbs raised. And one of the issues is not dissimilar to some of the other challenges we face. That sometimes people want the quick answer, more medicines, when maybe the best answer for them, the safest answer, what's going to help their health the most, may not be the quickest fix. And that's a challenge that I think we all have to work on facing. So I just look forward to hearing more from all of you about what is being done, what can be done, and quite frankly, what more we at CDC can do to support you here in the front lines.
Let's see if we have comments or questions from those of you to anyone on the panel. I think it's useful to, as I mentioned when I introduced Dr. Frieden, really he focuses on the emerging epidemics, the biggest problems that are coming down the path that are likely to kill the most people. 2 years ago was Ebola. But today, one of them is drug-resistant bacteria. And the second one is the subject that we're talking about today. So this is a frontline issue for communities all over our country. Who has a comment or a question? Yeah, Senator McNally and then Representative Dunn.
Thank you, Senator Alexander, for setting this up. I think it's very timely and be very productive. And I thank all the members on the panel and my two colleagues that are here, Rick Briggs and Bill Dunn, have been at the forefront of our fight, as Dr. Reagan knows, against drug abuse. Some things that I see that might be helpful to us on a national level are making sure that the registries, controlled substance registries, are able to get data from other states so it's seamless across the United States. We see the pain clinics, they'll pop up in one area, we close it down, next thing we know, they're across the border in another state. The same with the practitioners. In Tennessee's case, the most of the profession that prescribes most opiates are not the physicians, but the advanced practice nurses. And that's really an issue that we deal with. The other thing is, and this is on a national level, the ACOG guidelines, the obstetric guidelines about how you treat an individual who's addicted to drugs that comes in and is pregnant. And the guidelines say you carry them through the pregnancy with their drug of choice, and then at the end you attempt to treat the mother and the child. And of course, that's a great expense. I know with Keith over here at Children's Hospital, it's a tremendous expense for them and the other tertiary OB centers like UT. But to review those guidelines, because they were promulgated in the 70s, and I think newer data will show that in a lot of cases you could probably take the individual off, wean them off the narcotic, and then you have a lot better outcome in the end. But thanks again for what you do for us in the Senate and what all of y'all do for us in healthcare.
Any reaction to that from any of you?
I just would like to agree with that. I think that we are on the cusp of a much better understanding of the best way to treat a pregnant woman who needs medication-assisted therapy, and what the true effects are, what the true risks are for her and for her baby. So I think we're at the beginning of an exciting era where some of the previous assumptions and guidelines are being challenged by newer data.
Bill Dunn.
Thank you. I appreciate everybody here on the panel. I want to zero in on something that Dr. Dabbs said. In fact, it was the thing that got the applause, and so I don't want to get away from it because it is one of the most important things. We've got a group here at Knoxville that's worked very hard on this subject, and therefore we're getting a 10% decrease. I think if you looked at what the legislature has done, passing bills and stuff, we are very serious locally and statewide. There's something that's going on at the federal level that's screwing us, and that's the Prescaney survey. That survey is set up. That survey is set up, and Dr. Frieden, we appreciate you being here, and you mentioned about the appropriate amount of medicine given. That survey is set up to say, patient, did you get what you want? Not, patient, did you get what you needed? And there's a financial incentive for somebody to give 100 pills to a 72-year-old lady who's had shoulder surgery. And so the questions either on pain need to go, they need to be changed, but I think the best answer, keep the questions there so you can monitor and see what's going on, but take it out of the financial formula so that the hospital administrators aren't looking at the bottom line and saying, we gotta have good scores, because we gotta make payroll. So please take away the financial incentive for giving pills to people when they don't need it.
Now, we've got a couple of hospital administrators on the front row. And Dr. Frieden, we'll give, then, let's get Dr. Frieden's reaction, then if either of you want to say anything.
And I do have to think Senator Alexander's office was very nice to help set up the phone call I had with CMS. I don't know how far that will go, but I'm sure as chairman of the health committee, you can get her done.
Well, I will personally follow up with CMS as well on this issue. It's come up before. We've also followed up with the Joint Commission. They've tried to very clearly state that what their expectations are, the best treatment, not the most treatment, the appropriate treatment. And we've heard the same thing from other providers, and I will follow up, look at the details in terms of what's being asked, how it's being asked, how it's being weighted, and what are the options for potentially changing. Just thinking off the cuff, we could ask, did your doctor explain the risks of taking an opiate medication to you? That could be part of the evaluation as well.
Dr. Dabbs, you said something about that too, right? A moment ago.
Yes, I did.
What's your comment?
Well, I totally agree. I just think there's, and unfortunately, there is the perception. You know, I think there is a fine line. I've given seminars around the Southeast to emergency departments, physicians and nurses, about patient satisfaction issues and about pain management. You know, and we want to take care of the patient, and we want to be very sensitive to their needs, you know, not their wants. And there is, again, there's just this fine line about what's in your eyes when you look at a patient and say, David, I know you sprained your ankle, and I know in the past you've had Percocet for this, but I don't think it's best for you. And they say, yeah, but that other stuff doesn't work. You know, Advil doesn't work. I need my Percocet. David, you know, I'm going to explain to you again, you know, I don't want to get you addicted. And I've had patients say, are you telling me I'm a drug addict? And so suddenly there is a barrier, and I'm saying, no, David. Now, you know, the time is ticking. I got patients to see. I don't, you know, I wish I had 30 minutes to educate you about the ills of this medication. So there is a time pressure, and there is a fine line about the ability of physicians in that kind of environment to say, I love you, David, you know, but I can't give you the Percocet. Is that, do you understand? And I rarely, and I do this all the time, I try to convey that through my eyes. Do I hear the patient say, well, thank you so much, Dr. Dabbs, I want to give you 5 out of 5 on your survey. You're good with that. It's just a very tough situation to deal with. And again, having them not expect and in some sort of way be educated early on throughout their lives, and it's got to start somewhere, that, you know, it's probably not good for me, even though I'm probably going to hurt more with my Aleve or whatever it is. You know, it's okay because I really don't want to take. And it's, you know, and Senator, one of the things you talked about, or Tom, you said, you know, we're good for 48 hours. I mean, you'll find most ER doctors, we do not want to prescribe. I mean, it is the bane of our existence, is having to confront drug seekers and deal with this. It's a real issue. We've given the appropriate pain medication when they need it. But it's those other issues where you're just trying to understand what I can do with that patient. And we don't want to give 10 days. And I can't imagine, I've never prescribed a long-acting narcotic in 37 years. Never had that. I can't imagine any of my physicians doing that. But I'm sure, again, somebody may do that because that's what the patient has said. That's what I want. I can't see my doctor. And we give them 48 hours and they say, but you know, there is no way on earth I can see my primary care doctor, get a hold of him in 48 hours. So I'm going to be back to see you, Randall, in the ED, because 48 hours ain't enough for whatever my condition is. It is just a fine line, and it's not there's the best path. It's not the easiest path, but there's a best path that we can lay out that will give our physicians the best chance to kind of take care of the patient and yet not overdose them.
Dr. Lacey, do either of you want to make any comment?
Go ahead.
Well, I'd say a couple of things. One, that the pressure of the press gaining survey, particularly for Medicare and loss of payment, is real, and that is just one of the many challenges we face. I'm on the Children's Hospital side, and I'm also chairman at the moment at the Metropolitan Drug Commission Board, so I appreciate all the kind statements that have been made. The staff is here, and they've done all the heavy lifting and work to try to advance this issue. In the last 4 years, we've recovered almost 1,200 babies who were born dependent on drugs. One of the things I'd love to see is some longitudinal research on what's going to happen to these babies as they grow up. And frankly, we don't know what the long-term implications are going to be, but it's a very serious problem in our region. You mentioned the word epicenter. It is truly an epicenter in this area. We've worked hard with a number of coalitions to try to address the issues. I think one of the bigger problems that we can't solve today, because it's right up there with world hunger and world peace, is we are an addictive society. And if we move off of pain medications, you're seeing this in other states right now, they're moving right into heroin, which you've mentioned. And you go from heroin, you go to the next addictive thing. I don't know how we get out of that cycle, but it's been there for all of my lifetime. A couple of tactical things I think we could begin to do immediately in our community, and this is really related to the pregnant women, is test all of them to determine whether there's drug dependency. Some OBs do that, some perinatalologists do that, but not all. And the sooner we find out what the problem is, the sooner we can begin to affect treatment. Whether we do, as Senator McNally is suggesting.
I'm clapping because I'm going to get them next.
There you go. Absolutely.
Test them, please.
Whether the science around whether you begin to deal with the mother while during pregnancy or post-pregnancy, I think that needs to work itself out. I think the science is moving towards your suggestion. But we have to do that, and I think testing and requiring that will be a good first step. And then the other is education. We have to educate the pain clinics. We have to hold them accountable for educating their patients, not just dispensing medications. And some of the pain clinics are outstanding. They're very professional in the way they approach this with their patients, some of them less so. And we've seen a huge increase in pain clinics in the last 5 years in our community, and there has to be a correlation between the growth in those clinics and the problem that we're facing today. So I think we need to look at some real tactical issues that we can implement immediately. I also think we need to be looking at the long-term implications, and if we could ever figure out how to reduce the addictive nature of us as a society, that would help us all tremendously.
Thank you. Now, we've got about 5 more minutes, and we've got several hands that are up. Let me ask Mary Sumter-Lipinski. Where Mary Sumter? She's right there. She's head of our health team in our Senate Education Committee. If there are things that you don't get a chance to say to me today, and I welcome you saying later, or to Mary Sumter, who's in our Washington office, we'll also get the same kind of not a 1 hour fix for everything. So why don't we, Dr. Lacey, and then back there, Tim, did you have something you wanted to say as well? So, did you have anything? Okay.
Really, just I think it's been well stated. There are sort of perverse incentives that are out there that are going to be relatively easy to address. It just needs to be recognized and dealt with. The other question I have, Dr. Frieden, is what kind of investment are we making as a country to look for alternatives for pain management? And you may be up to date on that, and I'd appreciate that information.
Yeah, our research efforts underway. One of the ones that is encouraging that may get licensed in the next year is an injectable, long-acting form of a medication like Suboxone that would last for 6 months or more. That would be an important modality of treatment. Whether it's safe and effective, the FDA has to decide. I don't know about that. But I do want to come back to something said earlier. There are broader issues here than the medication. And on the one hand, I don't think it's entirely the case that, if we stop one thing, something else will come up. I think part of what's happened is we've created a number of people with addiction. About 75% of the people who are using heroin now started with prescription opiates. And if we hadn't started them, many of them would not have gone on to use heroin. At the same time, there are things that we need for the whole community to be dealing with, whether it's economic issues or jobs or activities available. It won't prevent everything, but it will make it easier for people to not start and to stop if they're addicted.
Thanks. Let's go back there, and then to Tim. That'll be our last comment, so that we can conclude the meeting. Yes, ma'am.
Thank you. I am I'm Dr. Suzanne Bailey. I'm a psychologist, and I direct the alcohol and drug programming at Cherokee Health Systems, a large federally qualified health center and community mental health center. So one of my stances on addiction treatment is always access to treatment, especially for the indigent and uninsured. So I'm very interested in how these funds will impact the ability for the uninsured in our community to access treatment. It's especially interesting to me. Yesterday, one of the last things I did before I left was to help a man who was in active addiction and withdrawal try to access treatment. When I went this morning to figure out what happened, I found him on the Knox County 24-hour arrest list. So I think that really access to treatment, especially for the indigent in our population, is one of the biggest problems. I think another thing we've seen recently in funding initiatives is the requirement for medication-assisted therapies to be a component of treatment, to be able to receive funding, and I would hope that that would not be the case here, and that all evidence-based treatments would be embraced as and be able to compete evenly for these funds.
Okay, thank you very much, Jim.
This is almost my 10th anniversary being judge of the juvenile court. My kids in custody number has changed from 300 to nearly 800 in that 10 years. The increase is solely due to prescription medication abuse. Court of Appeals, very active, affirming every time we take a baby born. We're breaking that bond between the mothers and the children. It's a terrible thing. Breaks my heart every day. I'm doing it with the same number of people that I had when I was taking care of 300 families with children in custody. Now I've got 8. I feel the pain from children's, from UT. I'm in a unique position to have a young doctor daughter. And our roundtable discussions are interesting at my house. I can tell you the training she received at the University of Tennessee residency program was excellent. I mean, she's trained to spot a drug addict. I think the medical profession with the young doctors is really doing their job based on my observation from her. I just don't know why it's okay for these mega companies to make more that can never be taken legally. I don't get that. My job went from straightening kids out to a very painful job every day. Law enforcement, catch anybody that's making money on these things. Catch them all. Lock them up forever. They're destroying our families. Senator, I thank you for having this conference, but I can't believe that companies are making billions off of hurting our people. Billions. I don't blame the doctors. I watched my daughter struggle on where to go to work because this place was her pay was going to be based on a survey of how much her patients liked her. And she said, everyone I don't give drugs to, I'm going to get a 0 out of 5. And she didn't choose that place because of that survey. There's a whole lot of facets that we need to work on together. We need a protocol in Knox County for pregnant women. What is the right treatment for a pregnant, addicted woman? How do we save the child in her womb? We need an agreement. What's all right? What's not all right? Some of the kids I see in the very worst shape that are in the NICU the longest, and I'm not knocking methadone. It may be a perfectly suitable treatment if you're not pregnant, but my methadone babies stay longer and seem to hurt worse and have more after effects than the ones that are in there on opiates. And as far as I know, it's a legal form of treatment for pregnant women. I'm telling you, it's not working from the juvenile court. I'm talking to Webster. You got a waiting list, Webster?
Nope.
Talked to Helen Ross McNabb last week. You got a waiting list? No. Talked to Centerpoint. Got a waiting list? 9-10 months. Can't get beds. Can't get dry out beds. 10 years ago, I don't know how long ago was it, Webster, we talked about Vivitrol? 5 or 6 years. We didn't have it here. Now it's available everywhere. It's a shot that stops the craving. These are physically addictive, sick people. They're really sick, and a lot of them aren't getting well. We don't have anywhere to dry them out. Can't even give them the Vivitrol until they've been dried out, what, 10 days? You guys are the treatment experts. But, you know, I see my DCS attorneys, my DCS workers, just worn out. Can't even hardly look up at the end of the day. The system's breaking because of this one epidemic. I hate to say this in a public place. Give me the heroin. It's legal. I mean, it's illegal. We understand it. We know what to do about it. Yeah, it's the same terrible addiction of physically addictive substance, but give me that one. That way when they're in court, I can deal with it. They don't come waving a prescription in my face saying, it's okay, I got this, Judge, it's okay, I've got a sore ankle, bad back. Give me the heroin, at least we understand it. And we understood cocaine before. I don't even have any cocaine cases now. Nobody wants cocaine anymore. They want Opana, Oxys, Roxys. Oh, and if you're on Vivitrol, they have now figured out that it's okay to take benzos. You can probably get by on some benzos when you're on the Vivitrol. Nothing seems to be working, and the hill keeps getting steeper to climb. And we're going to keep fighting one kid at a time. But I'm so glad that we have this kind of involvement. It's going to take a multi-front approach, but don't leave out the manufacturers. Don't leave out the manufacturers.
Thank you, Judge. That's eloquent, and it's very, very helpful. The reason we're here is because we have a big problem that's bigger. We have an epidemic that's more severe in Tennessee than some other places, but we also have in Knox County and in our state a greater effort to try to deal with it, as represented by the number of people who are here today, by the fact that Dr. Frieden has for 2 consecutive years selected Tennessee in a competitive grant to try to support the efforts that those of you who are here are making. So I congratulate you on that, and I'll follow up with Tom on this survey business and see what a sensible solution to that is, Bill and Judge and the others who mentioned it. I want to thank Dr. Buchanan for letting us come to her home territory, to Austin for coming and telling us what's a difficult story, but as Tom Frieden said, for you to do that helps put a human face in front of the statistics that we talk about. I'm grateful to you for doing that. Dr. Reagan, congratulations for your leadership. Dr. Dabbs, you've had a lot of practical experience, so we thank you for participating. Dr. Frieden, do you want to make a closing remark, and then we'll end the discussion?
Well, just to say that thank you, Senator Alexander, for your leadership on this issue. This is a problem that people made worse and people can fix. And we can do that by working together. We can do that by fixing the way we prescribe. I'll definitely follow up on the CMS issue. I don't think it's going to be quick. I don't think it's going to be easy, but I do think we can make this much better. Just look at the issue of motor vehicle fatalities. We cut those in half with the partnership, communities, public health, law enforcement. I think we can do the same thing for this problem.
Thank you for coming. The meeting's adjourned.
Can y'all announce I live streamed it and how to get it?
Sorry?
Can y'all announce that I live streamed this to Facebook if anybody wants to see it?
Yeah.
Hi, I live streamed both events, so if people want to see it again or check back with it, I can tell. I just want to know it's available.
Oh, okay. Great. And this is our press, my husband, a press person, and